Hello and welcome to our third series of everything about nutrition and hydration. And today we are talking about the appropriate prescribing of nutritional products. So first, some introductions. So I'm Vittoria Romano. I've been in the previous two podcast series and I am a community dietitian. So I work for Central London Community Healthcare Trust, specifically in West London. But I'm also the chair of the Older People Specialist Group, part of the British Dietetic Association. So I have a keen interest in older adults and supporting older adults to age well. And I have two colleagues with me today who are experts within the field of prescribing and prescribing support. So Alison, if you could introduce yourself.
Certainly. So I'm Alison Smith. I'm prescribing support consultant dietitian in Hertfordshire and West Essex ICB. And I am also on the committee of the Older People Specialist Group of the British Dietetic Association. And I'm the chair of the Advisory Committee on Borderline Substances, ACBS, which is a government, basically, advisory scientific committee for the Department of Health around products for prescription that are nutrition related.
Thank you very much. And Emily, could you introduce yourself?
Hi, morning. My name is Emily Rose. I am a prescribing support dietitian working for the Sussex ICB, and I wrote the BDA online module on appropriate prescribing for dietitians.
Thanks very much. And it's great to have you both experts here with us today to talk about this quite complicated topic. So we are here to talk about the appropriate prescribing of nutritional products. And this is quite a broad spectrum of products. We are going to focus the session on oral nutritional supplements, so abbreviated often to ONS. And the reason why we're going to focus specifically on ONS is because it's probably the largest spend to the country dedicated to this group of products. So I think at the moment it's sitting at about £14 million a month. So it's big money. So it makes sense that these products are appropriately prescribed and deliver value to the NHS. So I think a good starting point is perhaps starting with you, Alison, as chair of ACBS, is really to go through what is ACBS in more detail and what products are we talking about here?
No problem at all. So, as I said, ACBS, it's the Advisory Committee on Borderline Substances. It's a scientific advisory committee that sits under the Department of Health. We're not employed by the Department of Health, and it's a totally voluntary committee. There are, I think it's 15 or 16 of us on the committee. Most are dietitians. There are a significant number who work within prescribing support as well, so obviously have expertise in the area of appropriate prescribing. It covers almost everything that relates to nutrition, so not just oral nutritional supplements. It covers the baby milks that are used for calcium protein allergy, so extensively hydrolyzed and amino acid baby milks. It covers products for people with inherited metabolic disorders, so things like phenylketonuria. It covers low protein foods, which are also used for people with inherited metabolic disorders. It covers tube feeds, it covers products for pediatrics, it also covers gluten-free foods, and there are a few other things as well, including thickeners for people who have dysphagia and require thickened fluids. So there's a number of products. I think we're up to about 700 products that are covered by ACBS at the moment around nutrition. There's also a small number of products on ACBS that are actually skin products, but there's probably only about 10 of those in total. And we do have an expert in dermatology who looks at those.
Great. So it's a very vast area, and it's got quite a lot of experts in there to really support around what it should be available to be prescribed at NHS expense. It's also worth probably noting that some of these products are now considered under NHS England as items that shouldn't be routinely prescribed in primary care, some low value items. Is that right?
Yes and no. So there are some nutrition products that are considered low value items, so things like probiotics, and actually there are no ACBS listed products that are probiotics any longer. They used to be, but they have basically been removed. And the one that is remaining, that again we're looking at removing from ACBS, is an eye vitamin product, and again that's listed under NHS England as an item of low clinical value. So we're really keen to make sure that when these products are prescribed, it's because there's a genuine medical need, so that whenever anything is approved as a new product, it's always looking at it being approved for prescribing at NHS expense. And so we're always looking at, how is this adding value? How is this supporting patients? How is it supporting the NHS? So things do not just get approved because they have been presented by companies. In fact, we do push back quite a lot to companies where we don't consider that a product is required, that we don't consider that it's a good use of NHS's money, that we don't consider that it's a product that would be needed by patients. So there is actually quite a lot of pushback and quite a lot of scrutiny for every application that comes in. So it's not in the way that I understand a long time ago, the committee used to be regarded, I think, as a bit of a yes committee. It's certainly no longer that. I don't think it's been that for quite a number of years, but it's very much a committee that is happy to say no if we need to, which is fairly often actually.
Perfect. So that explains it really well, and I think it's worth being very clear that your jurisdiction, or at least what you focus on, is primary care, community prescribing. ACBS doesn't cover the hospitals, or at least secondary care. And so that's where perhaps some clear distinctions, or at least clear discrepancies may arise. What might be appropriate in a hospital setting, for example, may not necessarily be appropriate in primary care. So again, products and an issue needs to be reviewed on a regular basis if that's the case.
Definitely.
So we're here to talk about appropriate prescribing. So perhaps, Emily, over to you in terms of what are the sorts of things we should be looking at when we want to try and get the appropriate prescribing of these products. What should we be looking out for?
Thank you. So I think in order for prescribing to be considered appropriate, we need to ask a number of questions. So first of all, does the prescribing meet a need, a clinical need? So has that clinical need been identified? So that's the first one. And then the second one, we need to ensure that the prescription, the treatment or the management, whatever we're calling it, has an evidence base behind it that gives us the confidence that it's going to have clinical effectiveness. Because if it's not, why are we prescribing it? And then I think the third sort of strand of thought needs to be associated with cost. Is the treatment that is being prescribed an appropriate cost, an acceptable cost, and is there an acceptable balance of sort of risk to benefit involved in that?
I think, in terms of what can be useful, so most areas will have someone like us, prescribing support dietitians, working in their area, and usually these types of dietitians will often lead on perhaps a formulary, developing a formulary, a guideline, but of course developed in conjunction with key stakeholders, so pharmacists, dietetic teams that work in those areas, and primary care, so including GPs. So I would say kind of going to that formulary and looking at that formulary or prescribing guideline would often be a really useful port of call to check and see actually what products have been given the first go ahead if we particularly want to think about cost and clinical effectiveness. So that's usually a good place to start. So I think what I really picked up there was identifying the nutritional problem and also identifying the clinical need. So it might be worth going a little deeper into that. So I don't know, Alison, if you wanted to perhaps take this. one in terms of identifying the problem and also thinking about that clinical need.
Absolutely. So it's identifying the clinical problem. Ultimately, it's going to be exactly as Emily says. It's a clinical condition that is causing malnutrition. So effectively, it's a disease, disorder, or medical condition that is causing malnutrition. And really, that's the first thing. So you need to be able to demonstrate that as well as possible. We know in the UK that MUST, the Malnutrition Universal Screening Tool, is the most commonly used measure of malnutrition. It is not perfect, but it is at the moment probably about the best thing we've got. So actually using that to demonstrate level of malnutrition is helpful. There is also the Patients Association nutrition checklist, which can be useful too. It's a more subjective tool that is easier to complete, so it may be more helpful in primary care to use as well. But you need that as a starting point. Then you need to be able to demonstrate why this person isn't going to be able to meet their needs using food, because as you said, Vittoria, we're going to, we're focusing on oral nutritional supplements, and the long and short of it is there's nothing in these products you can't find in food. And so actually, we've got to then make a really strong argument to show why the person is unable to use food to meet their nutritional needs. And when we're talking about food, we don't just mean sort of what somebody's going to have sort of on a normal daily basis, because you can increase the nutrition in food. We talk a lot about food fortification as dietitians, and what we mean, or at least what we should mean, is that we're talking nutrient dense foods, things that contain multiple nutrients. So energy, protein, vitamins, minerals, sometimes fibre if they're plant-based foods as well, so that you can actually improve people's intake using these foods, either added to already sort of the meals or snacks they're having, or choosing nutrient-dense snacks as well, nutrient-dense drinks. For example, a milkshake made with full-fat milk, dried skimmed milk powder, and a milkshake powder that has vitamins in, which is Aldi's own brand, Asda's own brand, Lidl's own brand, or Nesquik, nutritionally will provide you with pretty much the same thing as a prescribed oral nutritional supplement, right down to the vitamins and minerals. And so what we're saying is actually there's no reason you can't do this with food as long as you're able to access food. So actually that's a big thing, is can somebody access food? Are they able to do this? But if it's a social issue that's preventing them from being able to access food, that's not a clinical condition. Therefore, we actually need to be thinking slightly wider here. And so we may be needing to involve things like social prescribing to support somebody to access the benefits that they need potentially, to get the support they need for sort of caring, so that we're not just relying on these prescribed products, because ultimately there's nothing magical about them.
And I think that's a really, really good point, actually, because the way I like to look at something like a MUST tool or the checklist is that it's a conversation starter, but it's really important that we involve the individual themselves, the person themselves, around what their goals are, what are they wanting to achieve, and what matters to them. Having those what matters to me conversations as a starting point, and then it's looking at how we well, actually the underlying issue, as you said, what is contributing to this malnutrition that we've identified, which often isn't always the disease state as such. It may be other things such as social, food insecurity, loneliness, things like that, and then looking at where we can perhaps signpost. And it's about having a very integrated approach, and what's really beneficial is that the NHS is now moving in that direction where teams are coming together. So there's much more opportunity at the moment to not necessarily go for a prescription straight away, which there's all this other stuff that needs to happen first before we even start talking about prescriptions, and it's looking at food in that sense. I think from my experience, some of the I think sometimes GPs, it can feel like GPs in particular get caught in the middle, pharmacists get caught in the middle, where perhaps prescriptions have been recommended either on discharge from hospital or maybe from other healthcare professionals, sometimes social care professionals, sometimes the person themselves, and sometimes the family. So Emily, what would you say in those sorts of situations? How would you recommend that somebody in primary care can best handle those situations where perhaps there is that pressure?
I think you're right. I think GPs often do find themselves caught in the middle. I think the first thing is always going to be having a conversation with the patient to find out sort of what their knowledge base is and where you go from there. I think that a lot of prescribing in primary care is led by what happens in secondary care, and supplements are used a lot within the hospital setting. Now, the reasons for them being used within the hospital setting don't always apply when the patient has been discharged into primary care. So, for example, when somebody is in hospital, it is generally because they are very unwell. And when they are discharged, it is generally because their condition has improved. So the patient is no longer in the same clinical position that they were. Therefore, does the prescription still need to apply? There are also a number of factors that inhibit a patient's appetite when they are in hospital. So the physical effects of being in hospital and feeling unwell, the environmental effects of being on a ward where perhaps, other patients are vomiting or opening their bowels, where meal times are not necessarily at the time that you feel hungry, where you are having your meals in bed, which isn't where most people generally eat. You may or may not have had the opportunity to have a shower that morning. You may or may not have had the opportunity for decent oral care and to clean your mouth. You may be in pain. All of those things are going to have a knock-on effect on your appetite and whether or not you are eating the provided meals. And because supplements are readily available in hospital and far more easily available than extra snacks or modifications to the hospital food, they get used. There's a very sort of low threshold at which they may be considered useful for that patient. But those factors don't apply when a patient is discharged either back to their own home or into a care home. Within those settings, people generally have much more control over what they are eating, and so hopefully the foods that they're eating are going to be to their taste. They have more control over the times of day that suits them, hopefully, as well as, along with the medications that they've been discharged on, there will be medications that manage pain or nausea or constipation, and so those factors will be sort of reduced. And I think one of the other things that needs to be considered is a hospital is a medical setting, a home is our home, and food and meals are an important part of life. To continue a sort of a medicalized approach to nutrition with a prescription of supplements may not be the best approach. So if you're able to talk to the patient about, now that you've been discharged, how are you getting on with your eating? Are there things that you can do to either increase the energy density of each individual meal, or can you be adding in extra snacks between meals or extra nourishing drinks in between meals or before bed? Asking the patient perhaps what they think the nutritional supplements provide. Do the patients understand that the nutritional supplements, the prescribed nutritional supplements, don't have any additional benefit to what can be provided by food? Often a patient has the feeling that because they've been used in hospital, therefore they must be a good, if not better, thing than food. Whereas we know that they're not made out of magic beans. they are just made out of milk with additions. And as Alison said, there's no reason why you can't make up your own drink using milk, skim milk powder, and a milkshake powder, which will provide you with exactly the same nutrient intake, but will probably taste better. I think it's really important to ask the question of the patient, do they actually drink the supplements that have been prescribed? I think often GPs' prescription requests will come from either a family member who's concerned that somebody is losing weight, or an institution or another healthcare provider. I don't think any of us have ever come across a nurse who works in the community who hasn't told them of a patient who has supplements prescribed, and they know that they're prescribed because the first thing they see when they go into the patient's kitchen is this mountain of bottles in the corner of the kitchen, because many patients don't find them particularly palatable, or they manage them for the first few days, but then taste fatigue sets in. But patients don't always feel able to say that something that they've been prescribed they're not taking, because they worry that they'll be told off for not following the prescription. So, just ask the simple question, do you like them? And if the answer is no, well, okay, that's simple. Let's look for something else, because a prescription of ONS isn't the only option that we have. And if we give patients the knowledge that they are able to manage their malnutrition using foods that they like, foods that their family are able to either provide or help prepare or do the shopping with, that gives them independence and a varied diet and pleasure from meal times, all of that is important and to the good, and will hopefully help with the conversation about, well, just because you had something in hospital doesn't mean that you need it now.
And I think it's a really good point, in so much that actually it's not that difficult using a food-based approach. I think some of my concerns are that it perhaps seems as though you need to be spending a lot of money and adding lots and lots of different things to people's diet, but actually food fortification might just be 3, 4, 5 different changes in a day. And again, bearing in mind that people's tastes and preferences can change on a day by day and even meal by meal time frame. Actually, it's so versatile. Food is so versatile. So, I only said to a care home training session the other day that 500 calories of nutrient-dense ingredients, for example, might just be a glass of fortified milk that you wouldn't have normally drunk, some skim milk powder and some cheese in some mashed potato, and then perhaps a Greek yogurt with some skim milk powder added to it as a snack. So that's not very many changes, but that's about 500 calories, which is significant to somebody, and it's all nutrient dense ingredients. So perhaps to the show notes of this podcast, we can add some information about how easy it is to increase somebody's intake using food fortification and snacks alone, let alone the nourishing drinks or the fortified drinks that we can add to that. I think that's really important, but it's a way of showing love, because people generally like eating food, and it's a way in which the whole family can get together, or carers can help support the person that they're looking after. So moving on, the other thing that came to mind is outcomes. So how do we know that this intervention is having a benefit? And I think this is perhaps worth exploring for a little bit, because I think some of the limitations with using something like MUS, the Malnutrition Universal Screening Tool, is that it measures weight, but that might not necessarily always be an important or appropriate outcome to be measuring in the population. So we know that malnutrition can affect anyone at any age, but it does disproportionately affect our older adults, and particularly those that will have some level of frailty, because weight loss is a freed phenotype for frailty. So I think it's about being setting appropriate expectations, but I think it's about the multidisciplinary team thinking about, well, if we set ceilings of care, and if we're not going to be treating in hospital and we're going to be treating at home, and we're only going to be treating certain things that happen but not everything, I think it's important as well that we set appropriate expectations or on outcomes. So Alison, I don't know if you wanted to explore this a little bit, because I know we've talked about this quite a bit when it comes to outcomes and measuring value through prescribing.
Absolutely. And I think one of the things sort of picking up from Emily as well is making it clear this is about outcomes for the patient or the person. This is not about the outcome of the member of staff feeling better because they've asked for an oral nutritional supplement to be prescribed. Because I think, again, as prescribing support dietitians, I think we've probably all seen prescriptions where you think this has been done to make a clinician feel better, not to support the patient necessarily. Everybody's trying to do things for the right reason. Nobody's ever trying to do things for the wrong reason. We all get that. But actually, just prescribing a nutritional supplement doesn't necessarily change anything, and it doesn't necessarily improve things. Even if you can tick a box that says, well, I've done that, on its own, that's unlikely to be the solution in a lot of cases. So I think it is definitely looking at the outcomes. What is it that the person wants to achieve? So we're back to person-centered care, basically. What does the person want to achieve? We very often, as dietitians or as other clinicians, we set our outcomes based on body weight. It's an easy thing to measure, but actually, is it really the thing that we ought to be measuring or even thinking about? The challenge then becomes, if we're not going to set body weight, what do we set instead? I have to say, in all the time I've worked with older adults, which is quite a while now, I don't think I've ever seen an older adult who's told me which BMI level they want to get up to. But very often when you look at an outcome that's sort of, this is what we're going to achieve, it's get to a body mass index of 22. And the reality is, as I say, I don't think I've ever heard a patient express that. So that's clearly not a patient's or a person's desired outcome. So it's thinking about what is it that the person themselves wants to achieve. So I do think we need to include enjoyment and pleasure in this as well. I'm sure that isn't going to be a thing they're going to say, I want to achieve that. But actually, if we can do it with that, awesome. Because frankly, who's not going to want to improve that, basically, or maintain the pleasure of life? So quality of life for me is a really, really big thing. And it can be really simple little things. It's functional measures. So the things that someone is able to do for themselves. So it can be something really quite small. It might be, I want to be able to give myself a drink. I want to have the muscle strength to be able to pick up a cup and give myself a drink rather than someone else having to do it for me. It might even be something like, I want to have the ability to stand and get myself to the toilet rather than having to wait for somebody to help me. And those are really fantastic outcome measures. They're very qualitative. So you're not going to have a SNOMED code that tells you that you're achieving this in the same way that you would with a body weight. But the reality is it's far more meaningful for the person that we're working with. It's harder for us as clinicians to demonstrate this, but there are ways of doing it. And it is very much more person-centered because it's looking at what does the person actually want to achieve. And as we said, because it's linked in with frailty, it's linked in with sarcopenia as well, about this sort of loss of muscle mass, loss of muscle function, which we know happens very frequently in malnutrition. Frailty, sarcopenia, malnutrition tend to go hand in hand with each other. But actually, the more we can support somebody to maintain and, if at all possible, improve their muscle strength, the better things will be for them. And it doesn't necessarily mean we're trying to get people out running marathons. As I say, it can simply be as small a thing as being able to lift a cup to your own lip, being able to get yourself to the toilet. Those are still really important measures for people who have very limited movement, very limited mobility. They are, and they have huge impacts on quality of life. And as I say, tied into all of this is actually, if you can enjoy what you're eating and drinking at the same time, well, fantastic. Because enjoyment for a lot of people, particularly in a care home setting, can be the main thing in life. It's enjoying food. It's actually, looking forward to your meal is actually a really important aspect. And so if we can do as much as we can with food to make it as enjoyable as possible while achieving the outcome that the person actually wants, then frankly, I think we've done all the things that we as clinicians would be wanting to do. With, you know, we're ticking all of those boxes, but we're also sort of hopefully improving things for the person.
Absolutely. And I think, you know, this really brings home to me that nutrition support is about a multimodal and multidisciplinary approach. So I think as a dietitian, I'd love to see more dietitians taking those leadership positions in multidisciplinary teams, and really supporting the MDT around this, and thinking about what is it that truly a dietitian needs to get involved in, but also where can we as dietitians support our colleagues to enable some of those conversations in other people that are helping the person to achieve that goal of being able to lift a cup or walk to the toilet or walk up the stairs better. So I think those are really important things to consider, and that's why we need to be so careful that we don't just go straight for a prescription before considering all of this, and also thinking about what's realistic. I think we're coming to the end now. I think we've covered quite a bit around appropriate prescribing, but I just wanted to go into a few niggles that perhaps happen in the community that I think probably need exploring a little bit. And it's going back to prescribing guidelines. So with prescribing guidelines, quite a lot of effort goes into the development of prescribing guidelines, a review of products, what's available and what is going to be the most clinically and cost effective products to choose if a prescription should be needed. So this brings me on to a couple of products. So we've got one that are compact products, and the other is high protein, very high protein products. So Emily or Alison, who'd like to perhaps explore these products and why we need to take particular care when issuing these to perhaps more of an older population? Emily, over to you.
If I kick off with the compact products, because they get used a lot, I think there is a very mixed message given to our older population by the use of compact products. On the one hand, we spend an awful lot of time talking to the older population about making sure that they are maintaining their hydration levels to reduce the risk of UTIs and falls. And then on the other hand, they are prescribed a compact, i.e. low volume, small amount of fluid product, generally because the we are told that they can't manage a large volume. And I think that the not being able to manage a large volume perhaps goes back to asking the patient if they like the taste. Often patients opt for the lower volume because it's smaller, and therefore as there is less of it to drink because they don't particularly enjoy it. Maintaining fluid balance is really important. And so I think unless there is a clinical reason why the patient needs a low fluid intake, so whether that is renal or cardiac problems, it shouldn't be a choice that is used. It goes back to what is the clinical indication for this product. And if there is not a clinical indication that means that we need a low volume, a low reduced fluid intake, then a standard size product should be used to help patients maintain their fluid intake. If patients say, oh, well, you know, I feel full after, you know, having drunk half of it, fine. You don't have to drink it all at once. You can split the volume into, you know, smaller units, and rather than drinking it all at once, keep half in the fridge, come back and have it later. But I think it's really important not to give the impression unintentionally to the patient that we want them to reduce their fluid intake overall, and therefore a compact is an appropriate choice. Alison, do you want to bash on with the high protein bit?
Absolutely. So the protein side of things is really useful, and in a similar way to giving mixed messages. I think we've got mixed messages around the protein side of things as well. We know that older adults do have higher protein requirements than younger adults do. And so older adults may need more protein, but that doesn't necessarily mean it has to come from a prescribed product either. And also it's thinking about, well, how much protein is enough as well. So it's considering, do we really need to have a high protein product? If someone is eating, and obviously these are only ever supplements to what somebody is eating, they're never instead of, or they're almost never instead of what someone's eating, the likelihood is they're going to be having some protein anyway. Certainly that should be the advice that we're supporting people to have. It's actually asking the question of, do people really need lots of extra protein? Do we need a prescribed product that has lots of extra protein? And interestingly, one of the compact products that is on the market and is used quite frequently is a high protein compact product. So not only do we have the challenges of the compact products, exactly as Emily, you've just said, we have the challenge of actually having really high protein. And it's not that unusual to come across people being advised that they should have several of these products per day. Protein is known to be quite satiating in that it can make you feel fuller for longer. And so again, if we're actually giving people these high protein supplement drinks, we've also got to ask the question, is this potentially putting people off being able to eat enough to actually sort of meet their needs? Because obviously we're still talking about, we should be basing what we're doing on food and the enjoyment of eating and all of the things that we've just talked about. We don't want the products through various different things to be actually stopping people from wanting or being able to eat. And we don't want them to be given excessive amounts of protein, because ultimately our bodies can't store extra protein. If we eat more than we can absorb, more than we can basically take it at the point that we eat it, bodies simply get rid of it. We basically pee it out effectively, and that's a really important thing to bear in mind. So even having loads and loads of protein from these supplements doesn't mean your body is necessarily going to be sort of laying down loads of extra protein, because that isn't how the body works. So it isn't always something that we need to have. We need, again, a clear justification from anybody requesting a prescription for a high protein supplement as to why the person needs this extra protein, why they're not going to be able to sort of meet a lot of their needs from food. So oftentimes it's going to be things like somebody has a significant pressure injury that requires additional protein. But pressure injuries will require additional calories, they'll require additional vitamins and minerals, additional fluid as well. So actually, it's never just a single nutrient. Almost nothing in our bodies simply needs one nutrient, it needs multiple different things. So I think it is a case of looking, again, we're back to this looking quite broadly and saying, and what is the actual need for this product? Is there a specific requirement for this? Or what can we do using food and potentially supplemented by nutritional supplements, but actually, if you like, standard ordinary supplements, not necessarily the compacts, not necessarily the high protein ones. If somebody genuinely requires a supplement, it's probably going to be enough.
Absolutely. And I think, you know, I totally attest to the fact that we need to be thinking these are supplements, these are to be taken in between meals. And so I'm always slightly concerned when I see volume sizes of kind of 3 bottles edging onto 4 bottles, perhaps even more, of particularly these high protein products, because some of the vitamins and minerals in there are quite high, particularly looking at vitamin A. So we need to be really quite cautious. These are supplements in between meals. Any more than 2 a day, I think we need to have a very, very good reason why that's the case. And it's not just good enough that, oh, someone's continuing to lose weight, let's just up it. We really need to do that assessment that we've been talking about throughout this podcast. So I think that's really, really important as well. And I think, again, Emily, the fluid side of things, I think there's a great paper, an ESPEN paper, that perhaps we'll link to here as well, around fluid, and it's really well written, and it really just lays it down the line. Older ladies need about 1.6 litres and older men need about 2 litres, and actually it's really that signs and symptoms of dehydration actually can be dismissed. The only way that we can really determine that someone's is dehydrated is through a blood test. So actually the actions that we need to take is to encourage and provide good access to fluid, and so compacts don't really make that much sense, because why will we be focusing on one thing but then potentially causing dehydration, which is a significant health problem. So I think about 37% of older adults are found to be dehydrated on admission to hospital. That's 37 out of 100. It's a huge number. So yeah, we can't think about nutrition without thinking about good hydration as well. We need to manage the two and be realistic at the same time with the two. So I think we've covered quite a lot here, and so I think yeah, Alison and Emily, any last comments to make on this topic?
I think the only comments are really to say, think about why these products might be needed and why food couldn't be used instead. I think rather than simply assuming that they're there, therefore we can use them, we should use them, is actually thinking about, should we? Just because something's there doesn't mean we have to use it. And there may be a different way, a better way potentially, because the thing that I always think is, when it comes to oral nutritional supplements, and Emily I think has made this point several times beautifully, is that food is about pleasure, it's about enjoyment, it's part of life, it's about part of what we get out of life. It's about companionship, it's, you know, doing all of these things. And my question is always, where is that in that little plastic bottle of a supplement?
Yeah, no, I agree with all of that. I think again, loath to introduce something new right at the end, but I sometimes worry that prescribing supplements, especially if it's done inappropriately, masks a problem rather than helping it, because you may, you know, look at your patient in front of you, you know, think that they're looking thin, you know that from records that they have lost weight. You then look at their drug charts, you can see that supplements are being prescribed, and therefore, okay, well, that problem's been dealt with, let's move on to something else. Have to go deeper and have a conversation about whether or not those supplements are having an effect. And if they are not, then what is the alternative? But I think a better way of approaching the treatment of malnutrition would be to have a discussion in the first instance about what are the sorts of things that the patient likes to eat, how can we change their diet, and focus on food options, with supplements being considered as an option further down the line for a particular reason for that individual patient, rather than supplements being considered as the go-to option for managing malnutrition.
Absolutely. So I think, to summarize, really what we're saying is we need to identify the nutritional problem. We need to understand why that problem has arisen, and sometimes it's not always something that can be treated. It might be something that we manage but will never necessarily improve or go away, and it's about managing that. Sometimes that person may continue to deteriorate. We need to understand the underlying issue. Then how can we optimize someone's intake through food? Where can we introduce food-based approaches like food fortification, nutrient-dense snacks, and perhaps nutrient-dense drinks or nourishing drinks? And then perhaps once all of that has been explored, prescribed supplements might be an option in the short term to support that person once everything else has been considered. What are our outcomes? What are we hoping to achieve through that prescription? Has that person fully consented and fully understood what a prescription is there to do, that shared decision making? And then how are we going to review that and set the expectation that generally they are short term? And then, of course, who within the multidisciplinary team can support with that, and also thinking about where dietitians perhaps might feature in that leadership role to support that multidisciplinary team, I think are my take-home messages from this session with you guys today. So hopefully that's covered it well. So I think yeah, all that leaves me to say is thank you so much to you both on providing us with your expertise, and a really good session on what is appropriate prescribing, and hopefully supporting our prescribers in the community to be able to do the right thing and feel comfortable and confident with any prescriptions they might be adjusting. We will be adding some supporting information to this podcast, because we've mentioned a few resources and some papers, some evidence base that might be of interest. And any questions, please direct it to the North Central London ICB, and we will hopefully try and answer any questions. Thank you very much for listening.